Thank you very much. Good afternoon, everyone. Good evening. Thank you for being here, and thank you for your patience. So the Committee on Health, Tourism, Historic Preservation, Land, and Justice is called to order. This is a public hearing, Tuesday, October 15, 2019 at 5 p.m. It's about 5:15 right now. This hearing was originally set for October 3rd. The legislature was in session that day, so we continued it to October 10, but it was again continued at the request of GMH. And notices for this public hearing were disseminated via email to all senators, to the Board of Trustees of the Guam Memorial Hospital, to all main media broadcasting outlets on Monday, October 7, and again on Sunday, October 13, 2019. It's an oversight hearing, and we intend to touch on the following topics, but this is subject to change, of course. We want an update on the capital improvement projects, the unpaid withholding taxes, and generally the finances, staffing, the CMS, Centers for Medicare and Medicaid Services update, the status of prior concerns, and other general items. So I'd like to thank my colleagues for their attendance, starting with Senator Amanda Shelton, Senator James Moylan, Senator Joseph Augustine, Senator Terlaje, Senator Clint Rigel. Thank you, colleagues, for being here. Of course, I'd like to thank the Administrator, Lillian Posadas, for being here and for communicating with us in advance. And if you could, are there any Board of Trustees members here? All right, if they do arrive, if you could also introduce them, and otherwise, if you could introduce your team for now, and then I'd like to just say a few things. If you could tell us who's with you today.
To my right is Mr. William Kando. He is the Associate Administrator of Operations. To my left, we have Don Rabanal. He is our Assistant Administrator of Administrative Services. We also have Mr. Jeffrey Ventura. He is our Manager for Planning. And we have Christine Tucaro in the second row. She is our Deputy Nursing Director. Ms. Gemma Beth Zimbillo is our Assistant Nursing Administrator. And we have Paula Manzon. She is our Clinical Informatics Manager. And we have Mr. Carlos Pangilinan. He's our management analyst. And we have Dr. Lizama and Mrs. Pauline Lizama. They are the managers and physician who runs the clinic over at the DOC outpatient clinic. And those are our hospital team.
Rodalyn.
Oh, I'm so sorry. We have Rodalyn. She is our chief auditor, but she's also sitting and wearing the hat of acting CFO.
Okay. All right, great. All right, so this is an oversight hearing, and there have been many issues regarding GMH, of course, in the news and over the years, right?
Yes.
So I realize that we cannot solve everything today. We probably can't even learn enough details tonight of what, to satisfy everyone in the room. But and we're not necessarily here for, we need more money at GMH, because I think if anyone doesn't know that, we need more money to improve services at GMH, to improve that, 41-year-old facility, then, they, I don't know, maybe they've been hiding under a rock. But we know that can all, but we all want to know how we're going to improve, services to patients, and how our patients are going to benefit from the money that we are giving you. And we want to know, some of these are short-term, some of these are long-term issues. And we've seen different, governor's advisory councils. We saw a very detailed GMH task force plan and recommendations that they came up with. The trustees themselves, of course, have reviewed this over many, many years. And so we've got a long history of ideas, a long history of issues of concern. And so one of the things we want to do today is just make sure that we are all on the same page when we leave this room, that the public, that we have transparency, that the senators are all very well informed, and that there's hopefully no surprises, that come up, and that we can get through at least FY 2020 with the amounts that you have, and see the best that we can do with those, while we also engage and make plans for the long-term solutions. We want to, this is all really going to be dependent on priorities, right? So when it comes to the facility, we're going to need to know what the priorities are. When it comes to, medical equipment, we all want state-of-the-art medical equipment for our patients. We want supplies, we want the best services, and we're going to have to hear from you how you have determined to prioritize those, what are critical or what we might need to deprioritize at this time. And I think while the community is listening, that they can also know exactly what it is that GMH is working on and exactly what it is GMH is not working on at this time, for those long-term plans, for example. And that's where the community can also help. So we want to help you, and we want the community to help you, help us, and we're going to all need to work together to get this done. So, all right, so to begin, I know you have a presentation, PowerPoint?
Multimedia, it's in a paper format.
Oh, okay.
But it is in a PowerPoint format, slides. And so
All right.
these will be my talking points, bullet points in terms of updating.
Did you want us to put that up on the screens or not?
I didn't bring a thumb drive.
Okay.
Or I didn't bring my
All right, then.
laptop. It's just
So
going to be.
the senators have all been provided a copy of your presentation.
Okay.
All right. Okay, please proceed.
Okay, well, before I proceed, I need to apologize and introduce our FM manager, Mr. Zaudi
Facilities.
Tagadi. Facilities, correct. Facilities maintenance manager. So I apologize, I didn't introduce him earlier. But buenas and half a day, Senator Terlaje and senators. On behalf of the Board of Trustees, on behalf of the employees, our executive team, and staff and management, we thank you for giving us the opportunity to update you all, and also, as you mentioned earlier, to engage in the discussion, in the dialogue, so that hopefully, collectively and creatively, we can come up with some solutions that not necessarily requires money, because I do have some, recommendation, particularly for the nursing shortage, and so we'll talk about that later. In terms of the update with the facilities, on the first slide, the first item is the air handling units. Those are the air conditioning units and the overall system of HVAC, that is our heating, ventilation, and aircon system. We have 64 total units throughout the hospital. Recently, we upgraded and we replaced the first 2 units in the first floor. That's in the front entrance lobby and the rehab area, and at a price of $90,000 per unit. So we just started at that, and then we're going to be moving up to the second floor area. Aside from the ER, ICU, and the pharmacy, the remaining AHU units are over 30 years old, and so we're going to need to, really start planning to replace those units, particularly in the operating room on the second floor, because we're having some struggles with the AHUs and the HVAC in the operating room. The boiler units, we have 2 units at the hospital, and they're pretty old. One is 30 years old, one is about 20 years old. One of them, boiler number 2, went down on September 24. Right now, we have the contractor on site working. First, he did the assessment on the working boiler unit to make sure that it will continue to function while the other one is down. And so we are going to be procuring some supplies to fix that boiler unit number 2, to just keep it running. But however, we need to also think that, it may not last long. So to replace that unit, it's going to cost $500,000. Hopefully that it will continue to operate.
What was the price? You said 100,000?
500,000.
500.
$500,000 for one boiler unit.
So you intend to keep the other one operational and replace one?
Well, we need to have 2. We'd like to have 2 running, and that was what we were doing, having
But
2
is
boiler
one-
units.
right.
But right now, we're down to 1.
And that one can continue to operate?
Per the assessment of the contractor, it's in good condition. It's running.
These
It's
boiler
operating.
units were brought up in old reports also, so this has been a long-standing issue. They're old.
Yes, and we also included in the CIP for 2020 budget.
Okay.
So, and this boiler units, it's used for the water, hot water, and also for steam autoclaving and sterilizing the instruments, surgical instruments, and other medical devices. So we do need to have the boiler units, at least 2. The communication center, our comm center, is located in
I'm sorry,
the first
Lillian,
floor.
if you don't mind, I'm just going to allow very brief questions as we go along so we don't have to go back and forth, but if we can just keep them brief. And I'd like to recognize the presence of Senator Talina Nelson. Thank you, Senator. Ms. Shaw.
Thank you very much, Madam Chair. I just want to know, will you attempt to repair the broken boiler before you purchase the new one?
What was the question? I'm sorry.
Will you attempt to repair the broken boiler?
That's what we're doing right now.
Okay, so
we are repairing it, yes.
and that's at the cost of $500,000?
No,
That's
to
for an
replace
entire
it.
new one?
No, to get a new one, it would cost 500,000.
So the
Yes.
plan is for repair right now?
Right.
Okay.
Unless you have $500,000. Just kidding. Okay, any other question on that?
Matt, I have a question.
Sure.
From the very beginning, you identified 64 total AHUs,
Air handling units?
right?
Correct.
And you replace 2 at basically total 180,000.
Correct.
And then, the next lines goes aside from the ER and so forth and so forth. All the air handling units are over 30 years old.
Correct.
What is the message you're sending? You're going to replace all 62 left?
Well, we're just updating you that this is what our
But
facility
I'm just trying to
we're dealing
clarify
with.
your point here. And the reason why is just to know the number.
Sure.
If you're saying you have 64, you replace 2,
Right.
that means you got 62 left. How many of them are you anticipating replacing at the 60K? That's what I was leading to.
Okay.
So what is your answer to that? Your FM is here, so do you have an answer? Just
Well,
I just wanna look
again,
at the
they're
dollar
running,
amount.
they're operating, but
Okay.
rather than wait for it to break down,
I understand, and that's why I'm
So-
asking the question, is how many do you got this down? Just so we can know the numbers.
how many do we have that's working?
That's not working.
Oh, well, all 64 are working.
Oh, then there's no need to plan for, okay.
We're just updating you as far as what the
No problem.
status is.
Thank you. I'm happy. Thank
I
you.
think she told us that they recently replaced 2
Right.
for 90,000 each.
Right.
Done.
Yeah,
Okay,
that's
thanks.
done. Okay, all righty. The comm center, again, it's located in the Z wing that is yes, ma'am?
I'm sorry, are they energy efficient?
What's that?
The one that you replaced, I'm sure you're using energy efficient star.
Well, we like to
appliances.
make sure, right,
Okay,
exactly,
right?
that they're energy efficient, absolutely.
Good, good.
Yes. That's the trend. Okay. The comm center, it's located in the front lobby, the Z wing, first floor. And so the Z wing is the wing that we need, that's been condemned, and we need to get it demolished. But we need to, in order to get that demolished, we need to move and relocate the comm center. The A&E design has already been certified, it's completed. We bid out for, construction to then move. We just have to rebid it because we did not have any offers. So, it's going to cost $400,000, but the funding has already been identified by the DOI. We requested for a reprogram of the DOI funding. We got approved. So we've got the funding for that. We just need to find a contractor to get that started. So that's where we are with the comm center. And that building in the Z wing has asbestos, so we also need to be very cautious about it. Okay? The electrical distribution panel, this is another hot item, but we've been working very closely and collaboratively, and our FM team has been really working diligently and collaboratively with the GPA team. They've done a thorough assessment using their infrared, machine to identify what the hot spots are, and they have identified several. They've repaired them, they've replaced them. We just recently replaced a 600 amp breaker, which is a sub-panel of this electrical distribution panel. So right now, we're in good standing based on the expertise of GPA. They will be continuing to do frequent rounds at the hospital to make sure that everything again is all working in order and no hot spots. If they identify hotspots, then they will then get that replaced or repaired or resolved. Yes, ma'am?
This is the electrical panel we're talking about right
Correct.
now.
Right.
I think- I believe during the last administration, it was saying that it was about $6 million to repair.
We said the same thing.
Okay, because actually I heard it was 11 million this time around, earlier. So it's still staying at 6 million?
6 million, what the $11 million that you're probably looking at is the total amount of not just the electrical panel, the 6 million, the roofing repair, which is 5 million, the what was it? The EHR was, but the EHR was, no, the 11 million was for the electrical panel and the roofing repair.
Together.
The EHR was 21 million that we had identified in our budget request.
Okay, so 6 million is still just the panel,
It's
correct?
still at 6 million is what I understand.
So
That's based on formal A&E design cost estimate.
All right, Lillian, can you tell us then, in July 2018, maybe this is when you got the A&E,
Design.
the EMCE stated in their letter to you that it was, that the main electrical distribution panel replacement project will address the hospital's master plan, modernize the electrical system to be compliant with current code, increase system reliability, eliminate the imminent danger that can be life-threatening for patients, and allow for the hospital to grow to meet community needs. Have we removed the imminent danger? Are you confident about that?
I don't know if the imminent danger is what they're talking about with regards to where the electrical panel is located right now. It's right next to the water tank, the 20,000-gallon water tank. That's what I see as a concern. They're right next to each other. Electrical panel, water tank. That's not a good combination.
All right,
And
but
so, our plan is then, if the $6 million is to relocate one of those items, and it might be easier to relocate the water tank versus the electrical panel.
all right, so is the $6 million still an imminent need for the hospital?
To separate the water tank and the electrical panel, yes.
So despite the work by GPA, the $6 million is still needed?
I'm not an expert on it. We are going to have the Army Corps of Engineer when they come in November. That's one of their scope of work that we'd like for them to assess and determine what then will be the next plan to do.
See, it's not only next to the water tank, but it's next to our boilers. And boilers, if you could have a boiler explosion, that has been known to happen. And so there's multiple risks in our power plant with all of these systems very close to each other. And so that's a part of the risk. But the thing about so GPA has helped us, they're helping us sustain our existing panel, very old panel. If the Army Corps were to come in and say, your hospital is still structurally sound, you could expand it. If we expand the hospital at the existing site, we can't do it without replacing that panel. That panel has already reached its capacity.
Beyond.
So, but if they say, no, you're not structurally sound, you should be building a hospital somewhere else, then obviously we wouldn't waste money on buying a new panel. We would still work with GPA to sustain it while we're building a hospital somewhere else. So we really need this Army Corps of Engineers assessment to take place.
All right, please proceed.
Okay. The electronic health record, our EHR, which is synonymous with our electronic medical record, EMR system. We do have the EHR project, and Dawn is the project team leader. We sent out an RFP, and
Can
we
you
got...
please describe EHR? The abbreviations, I just want everyone to be able to follow along.
It's electronic health record, okay, which is synonymous with an electronic medical record. How, in the old days, you have an old chart with all your information and documents. It's now electronic. And so the current system that we have, it's administered by Cantata Health. It's called Optimum. That's going to be replaced, sunset by next year. So we have no option but to replace it. We need to find a product that will fit our needs. And so the RFI that went out, and we received 5 vendor packets. The project team has reviewed those packets to identify which one would probably be the best one for us to proceed with an RFP. but we cannot proceed with an RFP until we have the funding secured or identified, because we just cannot proceed with an RFP. But we have timelines, because we need also to present this to the Board of Trustees so they can then approve which product we select for them to then, approve. Then we need to go through the process of procurement, not just the product itself, the hardware, the software, and the peopleware. We need to train our people, because it's going to be a different system, and so we need to make sure we train people to use it appropriately. And so it's a cumbersome process, but it's important, and we need to go through that. But we're in a time crunch, because Optimum will sunset by next year, December 2020. It might sunset sooner than that. So we have to be ready to then have all of that in place to turn it on.
What,
Yes, sir.
what is the cost?
What's your updated estimate?
Okay, when we requested it, we were looking at $21 million. Recent communication from different vendors who have these products, it ranges anywhere from 40 to 50 million. This is an electronic health record
Say that again?
system.
No, what's the
40
amount?
to 50 million, but not up front. It's going to be throughout a period of probably 5 years.
So you're saying, basically, if you're saying 40 to 50 million, so divide that by
For
5 years,
for
so
5
you're looking
years.
at 10 million a year.
Well, if we could have at least the 10 million that you had allocated from the excess revenues, hopefully that if we get that secured, we can then begin the RFP. So, and depending on the responses from the RFP, which product would then best meet our needs at the hospital.
Ms. Posadas, not revealing what you got in the RFI, because if you got 5 packets that come in, not revealing who they are, but
Okay.
what is the amounts they provided? Did they
We
say
don't-
20 million? Did they say
In-
what? They didn't
in
give
the
you nothing?
In the RFIs,
Yeah.
Senator, they don't provide cost or price. It's just information on the product, what they offer, what, programs and what clinical modules they have
And,
that we can use.
and your folks will determine when you do an RFP,
At least we have a better idea what these products are.
or
so
what's
that
out
when
there.
Right, what's out there, so that when we do the RFP, we are more familiar with these products, and then we can go with the price, the cost in the RFP process.
okay, thank you.
I'm just kind of confused. You're going from 20 million. Actually, I have 22 million here first. And then it's such a jump from 22 to 40 to 50 now million. What changed?
Well, these companies, when they come out with these products of electronic health record, it's a vast product, and there's certain modules. It's not just like nursing. There's pharmacy, there's laboratory modules that, it's very comprehensive. And this is what these companies do. And also that, it's very important that when we have these the regulatory organizations, they require a lot of standards and a lot of reports. And so these companies, when they build their EHR system, they have to incorporate all of that. It is costly. It really is. And it has cost many hospitals large sums of money to have these EHRs
Yeah, I
because of
understand
these
your-
regulatory
yeah.
requirements.
I just don't see, from 22, now we're jumping into 40 to 50. Is that number going to change again?
There's a lot of EHR products out there, and so different prices. I can let Don speak more on it.
If I may, ma'am, the previous budgetary numbers amounts that was shared would be basically budgetary figures, right? One from a particular vendor. As far as the RFI documentation package, there were several indications of amounts, but nothing concrete. But during our next step, which is really crafting the RFP, which defines the great detail of requirement of each and every single department of the hospital, from nursing, from registration, nursing, the ancillary departments, lab, rad, pharmacy, so on and so forth, all the way to the actual medical records keeping, all the way to information sharing with the various different institutions, whether it be Naval Hospital, GRMC, the clinics, public health, so on and so forth. Up until we define that in great detail and then allow the vendors to actually quote, we wouldn't have a solid figure, so to speak. That's why it's very important for us to finish this RFP process with great detail so that we could immediately publish it and send it out, at least immediately to the first 5 vendors that responded within the RFI, and possibly more.
So the 22 basically was just part of the hospital's functions. And what you did now was incorporate all the functions in the hospital. Now that's why the cost is now 40,000 to 50,000, is because you first gave us 22. So my question is there any way that you can do some of it now and then later on incorporate, you know, like add more onto it? Is that possible?
There's definitely options to phase a project, but at the very least, the hospital now is aiming to define the overall requirement for the hospital as far as EHR is concerned. Because EHR the acronym stands for Electronic Health Records. What differentiates it from an EMR is that we have an ED service, which is basically outpatient. So anytime there's more than one patient setting, it automatically migrates to an EHR. We also have our SNF, which is our skilled nursing facility. That's another level of care, so to speak, that we provide our patients, our residents at SNF. And we're envisioning for all these types of services that GMH and SNF provides to be enveloped into a singular solution. Whether we could afford it or not, whether there's a great possibility to be able to phase it out, because the primary system that is sunsetting by the end of next year would be the clinical documentation software, which is the nursing notes, nursing orders, providers, physicians, flow sheets, so on and so forth. Which is unfortunately, as far as EHR world is concerned, that's the very first step that leads to medical coding that eventually leads to billing. So without appropriate capture of that information, there's no quality level of care. There's no, the data, information, the data that you capture that would be transposed towards information that could be shared across the next department would not be meaningful. And then eventually, again, it translates to billing that would eventually sustain the operations of the hospital.
For
So
this,
sorry.
for this medical coding and eventually billing, will this eliminate the avenue that has been used in the past where doctors double dip or triple dip to, so they charge the hospital for their service, and then they also lay claim to their practice outside in the clinic? Is this going to eliminate that, or are we still continuing that practice?
I don't know that it will eliminate, but it certainly makes it more accurate in terms of the documentation, translating it over to the medical records, billing and coding, and increase the efficiency to track it. Because right now, it is a challenge to track what these doctors are billing, and, because we don't have that information. We
Right, so
don't have that
they
ability
get paid through the
to know what these
hospital, and then
doctors
they
are
charge patients
charging.
at the clinic.
Exactly. Right.
Okay.
So, a really robust, a really efficient EHR system, that will then increase the efficiency of our ability to then make sure the accuracy of those claims and the completeness and the expediency in terms of getting those bills and those claims out.
Okay, thank you. So the answer is we don't know. Thank you.
What's
All
that?
right, Senator Shelton.
Okay.
Thank you. During previous hearings, we talked about the need for the EHR to be able to communicate with the system that we have at Public Health and the system in the other hospitals on island. Are you able to share with us if these 5 proposals address that or meet those needs that we were?
I'll let,
So as far as the RFI for GMH is concerned, we're primarily focused on the needs of the hospital and SNF. But you're very right, Senator. If there's one other infrastructure that Guam is currently missing now, that would be the Health Information Exchange, which is normally a government-sponsored infrastructure, where if all the facilities on island, private or public, outpatient or inpatient, urgent care or emergency, would basically contribute towards a singular patient record, which is again normally government sponsored. So that would give a better, I guess, record tracking, keeping, not only on the electronic health record, but on a billing public payment side as well. So that is outside of the purview of the current bid of GMH now, or at least the documents that we're trying to craft.
All right, now, I'll be frank with you that that amount is pretty shocking, and I'm not in the industry, so I'm not sure if this is standard, but yeah, I think we're gonna need a lot more concrete of how you came up with this number, how you intend to, frame your RFP, that it will be paid, like, what are you going to count on in that RFP? And what about, is this really what is going to get us to CMS compliance? Or is this way beyond what we actually need for CMS compliance? Is this the deluxe model, in other words? Or is it really what's going to get us there? Because that's our main concern. This is supposed to be for a CMS issue.
The electronic health records basically is just one component as far as CMS is concerned. It is required by CMS. There are certification requirements from CMS for software vendors as far as their products are concerned. Part of the reason, or maybe the primary reason why the incumbent vendor is sunsetting their product is because they didn't pass the latest CMS requirement, which is 2015 standards, which had an implementation schedule of that's the latest standard right now. So it is incumbent upon the hospital to be able to look for a replacement that complies with the most updated standards from CMS. I would say though, if we have a more robust solution that effectively captures and shares information, aggregates it and presents the data, information to the user, whether it be a clinician, a nurse, a physician, a coder, so on and so forth, in such a meaningful way, then that would help their own process, workflow, to be much safer and much higher quality.
All right, thank you. I guess we're going to follow up when you get closer to your RFP. Thank you.
Madam Chair,
Yes.
very simple question. Maybe because I'm prior military. If you tell me the CMS require you to have it, they should have a standard that they're going to tell you, you must meet it. You don't need to kick out an RFI. You just take what requirement they demand of you to get CMS qualified and then put it out, and then you'll know what the cost is, because the folks that are inspecting you know what you need to have.
Correct. But it
It's
also
the standard throughout the nation. I mean, I can't see Guam is any different. I'm not trying to debate with you. I'm just very curious. You're going to keep talking about CMS requirements? What is CMS requirements in your system? And I honestly believe if you follow that standard, it's basically telling you what kind of system you need to have. What is found at every hospital? It shouldn't be any different because they inspect everybody. And if that exists, I can't see you going on and saying, vendors, can you tell me what you got and this is what we believe we need? No. What the CMS requires, match it. If you want to grow from there, I'm not against that. But I'm just saying is this, like the chairperson mentioned, what is the standard that you need to pass CMS? Let's get to that because we can grow from there. But if we can't even get there because, like one of my colleagues said, from 22 or 21 it went to 40, 50, it's a runaway. It's a runaway train, and that's not going to work.
Right.
What is the standard? Let's follow the standard. Then we can get higher. The goal is to be the best hospital, not compete against private, but be the best because it's for the people of Guam. That's what I like to see.
Yes,
Okay?
and thank you for that.
Thank you.
And that the project team will make sure they incorporate that. At the same time, it also needs to fit into our environment, particularly the laws, the local laws, because those are different also compared to the other places. And so, such as,
Ma'am, if you're going to tell us the local laws is the problem,
no, it's not a problem.
no, all I'm saying is if the CMS says this and you're saying that the laws need to change
No,
because the
I'm not
environment,
saying-
then we make the change to meet CMS.
Okay.
Because it's a standard nationwide. Okay, and all I'm going to say is I'm here to support you and I want to get the hospital fixed. Okay?
And thank you.
We'll
But
move
I just
from
want to clarify that we also need to take into consideration
Yes, ma'am.
where we are. Thank you.
Okay, thank you.
All right, let's go ahead and finish up with the facilities, and we'll hold our questions until then, and then we can ask all our facilities questions. Thank you.
Sure. The next hot item is our elevator units. We have 4. Of the 4, 2 are functioning. Because of the water leakage, it damaged the internal electronic component of elevators 3 and 4, and also then 1 and 2. And so right now, we have 2 that are functioning, elevators 1 and 3. Elevators 1 and 2, we have procured the passenger carriage. So in order to get those installed, the contractor and the subcontractor with our FM team, they're assessing the elevator shaft if there are any other leakages, and if they find it, then they're going to make sure they repair that, they fix it. Also at the rooftop, they want to make sure that, whatever leakages, because we do have, an opening in the rooftop, but then it was closed by concrete. So that needs to then be assessed if there are any more leakages so that there's no water penetration, because there's no point putting in new passenger carriages and we continue to have the leakage. So we're going to make sure that that is resolved. And it's going to take like 3 to 4 months for each passenger carriage to then be replaced. In the meantime, we are going to make sure that we have 2 elevators continuously running. We just received a recent update on elevator 4. That's down right now. The motor recoiling needs to be replaced, and that's going to cost like $2,000 to replace it. At least $5,000. And then eventually we're going to need to replace that carriage also. Yes, ma'am.
Tell us the cost. The cost of each of those very quickly, if you
Total
can.
cost was, for the 2, was about $500,000.
That's what I thought. Yeah.
All right. Okay, please proceed.
Okay.
Generators.
Yes, emergency generators. We have 3 right now. 2 of them are 1.6 megawatts. One of them, we call it Old Faithful because it's 27 years old, but it's still working. It's still, providing electrical power when we are out. The other one is, it's another 1.6 megawatts. It's 23 years old. The 650 kilowatt, it's 15 years old. We wanted to replace that with a 1.6 megawatts. However, the contractor that when we did the RFP, IFB was estimating a cost of $1.6 million to replace the 650 kilowatt with a 1.6 megawatt generator. So we're putting that project on hold for now. The IBM servers, we have the Power 7 server that was acquired in 2012. It's pretty much reached its useful life. So we have acquired a Power 9 server, and it will be commissioning the 4th quarter this year. So we'll have a higher upgraded power server. Information technology, our IT and network infrastructure, again, it's an old network, equipment and cabling that is beyond its useful life. It's of 7 years. Oftentimes it results in outages or delays or hang-ups or hiccups and so congestion. So we do need to work on it, and the funding that we need to identify for that is $135,000. You have a question, Senator? Okay. Okay, yes? Oh, all righty. The operating room suites, we have 4 right now, but only 3 are really functional, and it ties in with the AHU and the HVACs, and so that's why we really need to upgrade those AHUs and HVACs. Emergency room, we have with the expansion and the modernization in 2013, we have 20 beds, 2 trauma rooms, and 2 isolation rooms. We get saturated very frequently. Just in the month of September, we had about 128 declarations of divert, meaning we cannot take any more patients because we are just full to the brim. And so we communicate with Naval Hospital and GRMC, and we let them know that we are on divert. At the same time, if they're on divert, they let us know. But that's one of our challenges, and the reason why we get saturated is because our beds on the telemetry unit, in the ICU, and in the medical surgical and surgical were limited. We have the beds, but we don't have the RNs to staff those beds and to accommodate and take care of those patients. That's one of our struggles, is the shortage of RNs. And, we have recruited about 55 RNs, but we've lost also 41 RNs. So we're still struggling with recruiting. And when we recruit nurses, we'd like to recruit those who are experienced, particularly for the ICU. We need nurses who've got the critical care background and experience and expertise, unlike telemetry as well, because telemetry beds are your cardiac monitoring beds. These are individuals who need to be monitored closely with their heart rhythm. And so that's where the demands are also, telemetry beds. And we have the capacity of 26 telemetry beds, but we don't have a full-fledged, full complementary of experienced RNs to staff it. We've recruited some nurses, but they're novice nurses. We need to also then make sure that we get them mentored and trained to handle these patients with telemetry conditions. So that's one of our struggles in terms of our bed capacity. Urgent care, that was opened in 2015 with the funds of the Healthcare Trust and Development funding source. Right now, we are open for service 7 days a week from 12 noon to 9 o'clock. And so that helps in terms of patients coming into the emergency room when they're triaged, their condition is not really an emergent condition, then we move them over to the urgent care area. So it helps, gives us that breathing room in the ER. The roof repairs, on June 26, we filed a claim with Moylan's Insurance. On July 28, they came and did a site inspection. And then just last month, we submitted to them you have a question, sir?
Please proceed.
Just proceed.
Okay. We submitted our assessment, cost estimate of $5 million, and so we're just waiting now for a response from Moylan's Insurance.
So you gave them the 5 million cost estimate?
Yes.
So you
Gave
got
them
all right.
Yes. Then the U.S. Army Corps of Engineers, they're going to be coming November 18th to the 22nd, and they're going to be using their Medical Center of Excellence scope of services to look at the facility stability and structural integrity and structural stability. Yes, ma'am.
Oh, I'm just really happy about the U.S. Army Corps of Engineers coming in.
Yes.
This is about a new hospital and being the opportunity actually to build one. While you
If that is the
continue-
determination, yes.
while you're continuing to put the Band-Aids on our current one right now.
We have to. We have to continue the operations,
Yeah.
yes.
So it's November 18th to the 22nd, they should have something. And this is not just the structural part. Is there anything else other than structural that the Army Corps of Engineers will also
The
be
electrical
assessing?
panel, they're going to take a look at that one.
That's
Life
structural.
safety, the roof, yes, many different components of the facility.
HVAC system?
You made a list.
Yes.
Oh, you did? Oh,
Could you just provide that for us?
Sure.
We will. All right, thank you.
The scope of services, what they gave us.
Scope
and
of
so we
services.
looked at it.
When do you expect their response to be completed?
They said probably around January, and the determination whether or not we can still then augment or expand and modernize the facility, or if we need to build a new hospital, and if we do need to build a new hospital, it's not going to be on the same site. It's going to be in a different location, because there's no room.
Well, they're not going to tell us that, right?
They're gonna
They're just going to do the structural facility, stability, the electrical,
Based
all
on
those
that
things
one-
that you said. Okay.
Yeah, they're going to, based on what they did with the American Samoa assessment that they did earlier, about 3 months ago, they did two recommendations and comparing the cost. And so that's what they said they would do also, is give us the two recommendations and the comparison of cost.
Focusing on, for GMH, focusing on the cost of like retrofitting GMH versus
A new
a
hospital.
new hospital.
All right, thank you.
Senator?
Ms. Posadas, I'm hoping that the assessment that you sent to Moylan's, and that's why I was tapping Senator Moylan, because I've been asking him about it to check his family. But I'm hoping that if they do award you the damages, that you can get it before the Army Corps does anything. Because this is long overdue.
Yes, it is.
The leaks didn't happen today. It happened for the past few years.
More than.
And I'm hoping that for the near future, whatever you're insured in, when there's a problem, call them and tell them you're claiming. Get every penny you got, because you're paying for it.
Yes.
That protects you. Okay, I
Absolutely.
just want to make sure.
Yes.
Thank you.
Thank you. Okay, and then the Z wing, again, that's already been condemned, and we need to get that demolished. The NE design is already certified and complete, so we just need to allocate 500,000 to $1 million to get that demolished.
Is that an urgent, is that urgent
Well,
It's a life safety issue.
yes.
to demolish it?
To demolish it, because if you come to the hospital, we'll walk you around the perimeter of that building. All of the columns
Are falling apart.
falling apart. And
Yes.
so we don't we want to bring that building down in a controlled manner instead of it deciding when it's going to come down to the next earthquake or whatever. We want to
Because
bring
there's
it down
possibly
safely.
asbestos.
So you have funds allocated for that?
No, ma'am? We,
No? We're gonna use GMH funds until somebody comes to our rescue to give us what we need.
All right.
We can't wait on certain things.
Okay, do we have any other brief questions regarding facilities updates? Senator Bridgell?
Thank you, Madam Chair. I just wanted to ask you guys what you think, because there's been a lot of talk about the Army Corps of Engineers coming and doing an assessment, and you've kind of mentioned they're going to assess it based on sort of whether or not it's more economically feasible to retrofit and repair facilities, or just tear the whole thing down and start anew. So what I'm asking is, you guys work there, you've been there for a while. When you guys look at it, do you think that they're likely going to say tear down and build a new one, or what do you think?
I don't think they're going to tell us to tear down and build a new one at the existing site. They're going to tell us what it would cost to retrofit it, and to retrofit GMH and not disrupt operations is going to be a very challenging issue.
right.
So you think they're going to present something that might lead you guys to want to opt to build at a new site?
I think they're going to give us the information that we need to know to provide it to the governor, Lillian and the governor, to
And
make an informed
legislature.
decision.
What I'm getting at is what you guys see there. You talked about the structure. There's different columns that are damaged, all these structural problems, facilities problems, all these other expenses. Do you think, just ballpark guess, do you think that it'll be more feasible to build a new hospital somewhere else rather than repair the current one?
What I can tell you is it's Zaldi and I, we've been doing this for the last 15, 20 years, retrofitting the hospital building, a new ER, new ICU. It's very, very challenging to do that and not disrupt operations at the very same time. And so to do it now on a grand scale, very challenging.
I'll be bold. I think a new hospital is what we need.
New hospital, right?
Yeah, and my recommendation is to build it near University of Guam. That way it can be affiliated with the University of Guam as a teaching hospital. We can bring in residents, we can bring in interns, that will build up our professional, pool of doctors and nurses and other ancillary health professionals. It's closer proximity for the people of the South. And,
Yeah, that's good for me.
grants, grants, we can get grants into, research grants. There's just those opportunities to have it in Manila near the University of Guam and
Is there
be
any land
affiliated.
there that's available in that area?
What's
you guys
that?
have you guys noticed whether or not there's any land available in that area?
Well, there's property there, but who owns it, I don't know. And so, something to look at. The Dean Circle has a lot of old buildings.
Lillian, are you proposing a formal recommendation?
I'm just telling you my answer to the question of the Senator.
Your
Rangel.
answer as the
I'm being
administrator of
bold
the
and being
hospital?
straight and honest that it'd be good to we need to have a new hospital. And my recommendation is by the University of Guam.
Are you working on that?
No,
that
ma'am.
Recommendation?
No,
Well,
ma'am, I'm
We
not.
sort of are by going through the process of working with the Army Corps first to really, do this in a scientific manner. Because they're gonna tell us more about what we don't know about the internal columns and beams of our hospital and that sort of thing. So we really don't know some of this. And so this is where the Army Corps comes in. And then the governor and Lillian can make an informed decision.
Board of Trustees.
Well,
And
it
the Board of
sounds
Trustees.
like the decision's been made,
No.
and you're coming here with a recommendation.
No,
That's
ma'am.
why I'm asking you,
No.
because, we want an objective assessment of it. All
I'm
right.
just
Senator
responding.
Rijal, any other questions?
No more questions.
Senator
Thank you.
Taitagui?
Well, I have a bill out there that's putting a task force together to build a new hospital, to go in that direction. It was years of work by Senator Dennis Rodriguez, who's been working with this task force. And I'm with you, Lillian. I think a new hospital is needed. There's been articles left and right showing that it costs way too much for us to keep putting that Band-Aid effect on the hospital that we have right now. And yes, there is land in Manila, and it is called a working zone to provide you the grant. So whatever Army Corps of Engineers say, I'm pretty confident they're going to say we need a new hospital. When it talked about the roof repairs earlier, you mentioned that the cost assessment from you was $5 million from Moylan's Insurance. Is there a deductible to that you have to come up with?
There is a deductible in the various sections, and so we're waiting for that formal reply from Moylan's
Oh, you don't know
to
the
determine
deductible?
what their determination is. Yeah, so.
But you should know your deductibles anytime you make a claim on any kind of insurance.
Yes, there's like 6 or 7 different sections of our policy, and each one of them has a different
Different
deductible.
deductibles?
Some of them are as high as $1 million deductible.
Wow, and
Yeah.
you're asking for 5 million, so that could almost be totally your cost.
Yeah. So you're right, that they may ask us to cover the deductible, and then they would pay above that.
I'd like to know that, that would be very helpful. I'm also looking at the budget that you provided us earlier with all these areas that needed to be, this is what I'm talking about, Lillian. All the costs of everything that needs to be repaired at the hospital. And one of the areas that you brought up was, at the end, was urgent care. And that was a very minimal amount. That's like, the cost on that is like $12,500. So my question now, from what you provided us during the budget hearing on these, how much of this has already been addressed?
None have been addressed.
None at all on this
No,
page?
other than the EHR, the $10 million.
Okay.
None.
So, did you get all of your $30 million from FY19?
We
We're going to get
20
to the finances
Right.
in just a little while, if you don't
Oh,
mind.
okay.
She's
Always,
got this
yes.
arranged in this presentation, and we'll get to that.
Right.
So, Lillian, on the facilities updates, Senator Shelton?
Yes, thank you very much, Madam Chair. I was reviewing your board minutes from June 26th, and in your report, Mrs. Posadas, you mentioned a discussion with CMS about an intermediate care facility. Can you explain to us what that is and if there's any progress on that?
There hasn't been any progress on it. It's still a discussion. And what prompted that is that we've got several patients in our acute care facility occupying acute care beds, but their level of care is at a point where they really don't need acute care from the nurses. They can be basically in a home setting, and a caregiver doesn't have to be an RN, doesn't have to be an RN, a licensed staff. They can be in a care setting with a caregiver, just to be there to make sure that they're safe, that their food is provided. So that's why we started talking about intermediate level of care, intermediate service, and we're trying to figure out where we can place those patients, because the SNU is a skilled nursing facility, and in there too, even though our capacity is about 24, more than half of those patients or residents that are up there are also at the level of intermediate care level, ICF, not SNF, but ICF. And these again are individuals, some are homeless, don't know where to go, no family support, so we keep them in the hospital, either at the acute care, especially if they have end-stage renal disease and they need hemodialysis. We can only keep them at the acute care site. We can't get them transferred over to SNU.
Do you have any idea how much an intermediate care facility would cost the hospital?
We're exploring that. We're also looking to see if we can work with St. Dominic's, and in fact, we have one successful story. An individual who's been with our facility finally got admitted to St. Dominic's. So we're working with St. Dominic's as well to see if we can place more individuals who don't have homes to go to, but at least they'll have a place and with caregivers.
Okay, I hope you can continue that relationship and we'll hear more success stories with St. Dominic's. Thank
Right,
you.
exactly. You know, the thing with St. Dominic's, if you don't mind my expansion on it, is that they only take MIP, and they require a $5,000 down payment. Well, these patients don't really have the funding source to pay that deposit, that down payment. So we're trying to figure out how we can then help them get over to St. Dominic's under the auspices of MIP, so that MIP will cover their stay there, their care.
I believe we had a similar discussion with the public guardian and the public health when they were here. All right. Okay, so the 3 top urgent items under CIP, if we can recap those. The roof repairs, you are waiting for a claim. We've been waiting for this for quite a while, since the summer, before the budget.
Correct.
When do you expect this to be settled?
Oh, I'd
You've
like to
given them their estimate in September only, and now, so when do you expect them to get back to you?
We've been in contact with them, but, you know, again, we're just waiting for them to give us a response.
Okay, because,
So we can contact again this week
All right.
and following week
and
until we
you're
get
going
an
to repair
answer.
the roof regardless of what Army Corps says, right?
We need to, because we
Right.
don't want any more leakages.
You're going to
We
repair
want-
the
right.
elevators regardless of what the Army Corps
Absolutely.
says. We
We
need this
need-
hospital to operate for 5 years, all right, and we need
The EHR.
the EHR for
Yes.
sure, and those estimates, you're going to get us more details on how you arrived at them, and I think those were the top 3, but we've seen now we have other emergencies that have come up that, and how you are dealing with them. So I'm going to move on to the financial standing.
Okay.
Our main concerns, well, you go ahead, and then we'll get to, we'll have,
Okay. Alrighty. As of August 2019, we sent out billings in the amount of $156.9 million. Gross projected revenues for this year was $163.2 million. Total cash receipt, what we've received in terms of the billings that we sent out, it's $118.8 million. Please keep in mind that some of this that we received were for prior years' billings and claims, and so that's what that amounts to. The accounts payable, you know, contrary to what has been thrown out there, 30 million is not true. Our accounts payable is 12.4 million as of yesterday. These are our vendors that we owe. Accounts receivables from like third parties, the insurance, the Gulf Guam 3Ms, and also from CNMI, medical referral. For third party is $15.3 million, and for Gulf Guam, $33.6 million. This is again still remaining for the end of fiscal year that
all
we're
right,
just
can we
waiting.
just pause right there? So you've got accounts payable of 12.4 million as of
12.4,
October
yesterday.
14.
Yes.
Accounts payable, does that include the taxes that you also put down here?
It does.
So that, including taxes, all right, 12.4
Yes.
total.
Yes.
And accounts receivable, you've got third-party payers, and then you have 33.6 from Gov Guam 3Ms.
Right. Medicaid,
Can
Medicare.
you, does that include the Medicaid claims that you also put down on the bottom?
Yes.
Okay.
No, these are just the subsequent bills that we sent out, so we're now waiting for them to be paid, for us to receive. The bottom that we received was already what we received, what we've collected.
Okay.
Okay, from Medicare, 10.7 million, Medicaid, 14.1.
Wait, sorry, what is the CNMI?
These are the stipend referral people that come through Guam
Okay.
from the stipend medical referral
All right,
office.
all right.
Yes. Mm-hmm.
On the accounts payable of the 12.4 million, how much of that that's like what we owe, right? Vendors?
Sorry, I got
Accounts
distracted.
payable is what we owe.
Yes.
How many
correct.
of that is in over 90 days?
I may have the document, but Rosalie, can I have you then? We have the report on it. I just don't have it off the top of my head, but we'll get that information.
Quite a
It's
bit?
not a whole lot for the 90 days,
Okay.
but I have that with me. Let me see if I can pull it out.
All right, if maybe, Rodelyn, if you could get that report to us. Lillian, if you could continue?
Okay, all righty. What we've collected so far then from Medicare, $10.7 million, from Medicaid, 14.1, and from MIP, 9.3. From the self-pay population, 12.7 million. I just also want to note that we used to only collect 15%, 15 cents to the dollar from self-pay. Since we've engaged these services and the support of the Attorney General, it's picked up to like about 30, 35 cents to the dollar of reimbursement from self-pay individuals. So that has really significantly helped us. From Gulf Guam subsidies, we received $22.4 million as of September 30th. That's from the $30 million that was authorized for fiscal year 2019. But, you know, we got the 22.4 because some of that was from the matching. You know, so we didn't receive the whole 30 million. There was still a balance. But because of the matching from the Medicaid, we got then the $22.4 million. Okay?
Right.
From the pharmaceutical funds.
I
we got-
checked with the Department of Administration, so they think that you received this amount as of August, and that as
Okay.
of September, they're showing 30 million, that you've received the entire appropriation for 2019.
Okay, all right, well, then that's great.
Is that
If we
correct?
have it.
You could just verify that.
Sure.
Yeah, we want to know whether you received your entire appropriation. That's the main question
Sure.
for us, yes. Okay, so according to DOA, it looks like yes.
We got the 30 million, okay.
Just real quick before you move on, back to the accounts payable, how much of that is taxes?
How much of it is the tax, the withholding tax that we owe for
Taxes.
2018? What we owe for 2018, in terms of just taxes from right now currently, because we've made payments for January and February invoices, we owe $4.9 million now, just the taxes alone for 2018. There are interests and penalty fees for the years 2014, not the whole year, the certain quarters in 2015 and certain quarters in 2017. The interest and penalty fees came out to be $40,000 for those years.
And for 2018, interest and penalties, that doesn't include.
The 2018, the 4.9 excludes interest and penalty. Yes.
It's down
If
on the
we
bottom. We're going to
add-
get to that, right?
What was that?
We're going to get to those details down in the bottom.
If we
you-
add
yeah.
the interest and penalties for 2018, that's another $2 million. So, you know, about 6.9 million is what we owe DRT for 2018 alone.
All right, wait.
Explain it again.
Yeah, please explain that again. So,
Okay.
okay, so you're telling us that accounts payable, 12.4 million, includes the withholding taxes that are due? On the bottom, you've spelled it out that withholding taxes that are due total 4.9 million,
Yes. So it's
excluding
included
interest and
in the
penalty, which
12.4
brings it
million.
up to
about 6.9
not
million.
8 point some, just 6 point? Because on the, I think on the radio, you had said 8 million?
We had the.
Total, 6 million as of now. 6 million?
Yes.
Okay.
For 2018 only.
Oh,
Right. 2014,
yes.
2015, and 2017, certain quarters, not the
Yes.
whole year, just certain quarters of those years, we owe only the interest fee and the penalty fees.
How much? How much?
$40,000 is what we owe for
Okay.
those years
Okay, got
in
it.
terms of interest
It's not listed
and
here.
penalties.
All right, so
right.
on withholding? On the withholding, any other questions?
That's 2017 too as well. I'm sorry, Lillian, you said 2014, 15, and 17, $40,000 in interest and penalties only.
Right.
At 40,000.
Correct.
Okay. And then 2018, how much in taxes? Of course, not including is 4.9 is what is owed, right?
All right. Just a minute, please.
Okay, sure.
Go ahead, yeah. Come on and explain. I'll let Rhoda.
Hi, good evening.
Good evening.
Okay, so as far as the withholding taxes is concerned, for 2014, 43,000 was just for interest and penalties. For 2015, and Ms. Lillian is correct, it's only for certain quarters. Interest and penalties is about, sorry, I broke it out separately, that's why. It's about 70.
I'd like to acknowledge go ahead. I'd like to acknowledge the presence of, there's two trustees here, Sonia Silang, thank you for being here, and Dr. If you want to chime in, you're welcome. If not, that's fine.
Okay, so
Rana?
it's about $300,000 in interest and penalties for 2015.
300,000?
Yes, in
Okay.
interest and penalties.
Well, that's different for 43, okay. So 43,000 for 2014, year 2014 on interest and penalties.
Correct.
2015, it's 300,000?
Yes.
Okay, and now we're going to 2017.
For 2017, it's about 350,000. Yeah,
350,000.
roughly 350. I'm estimating at the moment, but it's roughly there.
That's different from 43.
So-
Something else?
DRT,
Okay.
just on interest and penalties.
Yeah.
So in FY 2018, what is owed in just taxes alone?
No, not taxes. So let me explain. So what happened was when we got the bill, and then so in analyzing that, what was only owed in 2014 is for interest and penalties. There was no taxes. The taxes were paid.
Understand.
Likewise, for 2015, the taxes were paid. For 2017, same thing. So what is only owed for those years is interest and penalties.
Is there any taxes other than interest and penalty that's owed to revenue tax by the hospital?
2018.
Yes, but only for 2018.
And how much is that total? Is that 4.9
So
million?
that is the 4.9 million, yes, ma'am.
Okay.
So what's your total?
So the total booked, let me, in our books, just to be clear, it's 4.9 million that we owed DRT. And the reason for that is because Ms. Lillian has submitted a request for waiver of interest and penalties to DRT at this time. So because of that, the interest and penalty portion has not been booked.
All right, otherwise we're looking at 6,650,000.
Possibly.
And,
All right.
And DOC owes Guam Memorial Hospital.
Yeah.
2.4.
See, if you could proceed with your presentation, we'll get to DOCs. So we're on GovGuam receipts,
Okay. The subsidy?
either 22 or 30 million, right, as appropriated.
Okay.
And then Medicaid claims. Could you explain the Medicaid claims?
Yes, year-to-date Medicaid claims that we submitted was $44 million, and what we received in terms of payment is $16 million. So again, about 36% reimbursement rate, which
That's
is kind of,
normal?
which is kind of, because it mirrors Medicare, Medicaid mirrors Medicare, reimbursement rate. So it is within.
All right. Okay, now DOC receivables.
DOC receivables for all the inpatient care services that we provide, plus the outpatient clinics that we are mandated to operate at the Agana and at the Manila facilities, they owe us $2.475 million.
How long has that been, that
It
amount?
says 5.9.
It was 5.9, they've made some payments, I'm sorry.
Oh, okay.
That's an incorrect amount. It's 2.475.
Sorry, my
Yeah.
mistake.
They've made some payments, DOC has made some payments, and so they owe us 2.475.
For what year?
It's cumulative to current, and so, but, again, DOC cannot pay us for prior
That's why we want to know,
debts.
what years are these?
Let me get back to you on that.
So ignore the
started-
current you're going to get paid for. They've promised, right? It's the past years that are problematic.
Right.
So,
Uh-huh.
yeah, what is that, 2018?
We started running the clinic in 2015.
I think it's only 2018 that they did not pay. Is that correct?
Even 2017, I think, there was a period when.
All right, what do you have?
There was, my understanding is that there was receivables from 2017 as well. There was receivables for 2017 as well, 2018. Sorry, I'm going through my,
Okay, but you think it can't total more than 2.475? That's what you're saying now, today?
That's what we have on
All right,
record.
and is there any possibility of payment by DOC? For example, are they waiting for your invoices, or are they saying absolutely no way they're going to pay
We've been submitting
this?
the invoices. We've been submitting the invoices, but again, the funding has to come from DOA. It doesn't come directly from DOC.
Right.
So
So you're saying all invoices have been submitted?
we submit it on a regular basis, yes.
Isn't that wasn't that the issue that DOA had pointed out, that they were waiting for invoices from these past prior
That's what they
years?
claim, but from our accountant.
Your records show you're up to date.
Accountant says that we submit the invoices.
Okay, and so
Yes.
DOA also says that DOC cannot pay for
Prior years.
2018 because they were never
Budgeted.
budgeted to pay?
That's what I understand. They didn't have it in their budget, or they didn't have budget for it.
It makes no sense to us right now, but because, anyways, for 2020, they've said that they're going to pay the DOC bills through compact impact money, right? Did you receive any compact impact money for any of these DOC bills in prior years?
I don't recall that we have, but, yeah.
Can you check that, Rodolin, please let me know?
Sure. And also, if I can just make a correction, as far as the DOC billings, this actually goes way back to the earliest I see one from as early as 2001, and then it goes all the way.
But she just
that's-
said they began the clinic in 2015.
But we have inpatients.
I see.
They
Yeah,
come
because
into the
it's
hospital.
inpatient and
So,
outpatient.
yeah, we provide the care. Right,
Are you
exactly.
still carrying that on your books?
So there is one, because we ran this just as of yesterday, and so that's why I needed to pull up the information, because it was very vague to me. I knew that there's other dates so for prior years, so that's one, but then it goes from 2001, 2006, and then forward.
All right, well, the concern is that this is an issue that, if we could have dealt with it during budget times, we would have, just like we tried to ensure, without hearing, that there was a back due, that to ensure that you were going to get paid for 2020. We made sure of that, but yeah, so it's concerning to me that this was not, clear when we were going through those budget, because it should have been taken care of then. All right, any questions regarding the DOC or the withholding taxes? So what is your plan for payment of the withholding taxes? Let's say your fees and interest and penalties are waived. You have a plan to pay the remainder,
We have been paying every week.
but the past due.
Yes.
You are
on the
paying on the past
2018.
due. Okay.
Yes, on the 2018.
Any questions?
Yes, I have a question. Again, referring back to your board minutes, I see that you gave a report about delinquent and unpaid retirement contributions, including interest and penalties that amounted to $1.2 million. So is that accounted for here? in
We're
this
up to
now?
date with
Okay.
retirement.
Okay, great to hear. Okay.
Right.
Is there any liability that anyone's looking at for this non-payment of withholding taxes?
The letter that I got from DRT was that if we don't pay, they can put a lien on our bank accounts, on our assets, on our receivables. And so, that's what we receive from DRT, is that the potential for us to lose, or for the accounts that we have on our assets and our receivable, we won't get them. So that is a concern.
All right. Anything from the AG's office or anything like that? I'm talking.
Not from the AG's office. I'm in communication with the director of DRT, Ms. Daphne Shimizu, and so we're going to meet again next week to reconcile, because there are some discrepancies in our figures, in our records, and their figures into the records, and so we're going to meet to reconcile the differences.
All right. On the withholding, please, Senator Rija.
Thank you, Madam Chair. So you mentioned DRT sort of sent a letter saying that they could place a lien on some of the assets of GMH.
Correct.
Has that been resolved? Though usually in that case, when they sort of threaten to put a lien, you guys work out some sort of payment plan or structure, and that kind of holds them off from placing a lien. So did you guys enter into some sort of payment plan with DRT to pay down that 4.9?
We didn't enter into it, but the payments that we've been making on a regular basis, 1 week we make 2 payments, so they see our good faith effort
So they're
that
kinda-
we are
So they're kind of holding off now that you're making some
correct.
payments.
They haven't sent me another letter.
And then, but you haven't entered into any formal payment plan with them.
We don't have a formal payment plan with them. We are making the payments.
At the rate you're paying, how long do you think until you retire that debt?
Well, our goal is to get it done within the 6 months. That's our goal with our CFO and our acting CFO, is to get it done, repay all that's due in 6 months.
Okay, how will that impact operations? Because that's an additional cost that's not factored into your budget for operations, correct?
Well, it may impact it, but as long as we are on top of our billing and our claims and sending it, expediently and accurately and completely to the payers, we continue then to get the reimbursement. With Medicare, as of today, they're increasing their per diem reimbursement rate. As it was 1,646, they've increased it to 1,665. So, there's a little bit of, reimbursement increase there. But if we really continue to work with our billers and our coders to get those bills and those claims clean, accurate, and sent out, and we get the collection, we hope that we can stay on top of it.
Thank you. Thanks, Madam Chair.
Senator Teichler.
Well, we should tell Reverend Tax to go see DOC for that money, shouldn't we? But anyways, I know it's still kind of early in the FY 2020. How much money have you received so far in FY 2020? I know it's been like 2 weeks, so.
We've gotten some reimbursement, and we've gotten some money from DOA, and
You're
then
Lillian, you're allotted every month funding from DOA, correct? Every month? Or is it every 2
we should
weeks?
be getting every month from the Medicaid claims, yes, and
And-
MIP claims.
But from DOA?
It comes from DOA.
Okay.
Yes.
But the money that we appropriated in the FY 2020 budget, how much monthly of that is given to Guam Memorial Hospital?
I'm not sure that we've gotten anything yet. It's still kind of early, so we haven't gotten anything from DOA in terms of those pharmaceutical funds that was allocated for our operations, 19 million.
So every month you should be receiving how much?
Well, if we go on a monthly basis, 19 million, divide that by
It
the
would be
12
19.
months, we should be
Okay.
getting that. But, again, it just depends on the money that's available in the accounts. So,
So nothing yet?
Yeah.
Okay. Okay,
and
thank
the
you.
other good news that we received last week is that CMS is depositing $1.5 million into our account for the 2018 rebasing adjustment. So hopefully if CMS continues to reimburse us, that will keep our funding, our
That would
cash.
help.
Yes, absolutely.
That would help, especially paying down what you have to
Absolutely.
pay back, yeah. Okay, thank you.
Well, congratulations on the reimbursement rates and the rebasing. Can you just clarify, in the 2019, part of the 2019 budget was for labor and delivery ward, 600,000.
Correct.
How was that used?
We've used it for operations.
All right. Okay, we're looking now at the rest of this presentation, and I know that the senators are anxious to get to some of their questions, but go ahead. So we've got, just for everyone who's listening, we've got clinical standing, kind of general operations, and then HR issues we're going to discuss. And, okay, so please proceed.
I've discussed some of it, but again, on the clinical standing, we continue to be bombarded in our ER. 14,894 patients were seen, were admitted into our emergency room, and we continue to hold patients, 3,500 of them, primarily for the telemetry beds. These are our cardiac monitoring beds, and so it's in high demand. ICU again, 321 patients were waiting in the emergency room to get into an ICU bed. Sometimes they wait for 2 days. But, they still get the ICU level of care in the emergency room. They're just not in a room that is private in the ICU. Another area of patient care unit that is in high demand is the adult medical surgical unit. We do have right now a capacity of 25 beds. We have an additional in the annex 15 beds, but again, because we don't have the RN staff to, man that area, we can't open those beds. And so this is where the challenge of the RN shortage really comes into play and how it affects the patient care in the inpatient area. So, and total admissions into the hospital from different sources, either direct from the clinic or from the emergency room, 9,584. Total discharges for the year of fiscal year 2019, 11,255. And I highlight that because, the discharges on the average, if we have 30 to 50 patients being discharged, it impacts our capability for our billers and our coders to get those charts or those electronic records, complete and finalized so that it translates into a bill, a claim that goes into the payer. And when we only have 5 billers, actually 11 billers, but 4 coders, it can delay the process. And so, that's a large amount of discharges that we encounter on a daily basis. So we do need some resources in that area. Interventional radiology, this is our IR procedures. Dr. Rabati is our IR physician, and he does quite a bit of IR procedures, diagnostic and treatment procedures. And, he just recently did a TIPS procedure. These kinds of procedures, some patients normally have to go off island. So in essence, with this service is really making it available here on island with this high skills and high technology and, his knowledge and his expertise. It really is benefiting us to have Dr. Rabati. He generates revenues for us. And so I know there's been some contention in the media about his salary, but, it's what we need to have on our island. We need him to continue the services, and we don't want to lose him. So, I'm just highlighting that was something that was brought out in the media, and how, the doctors are criticized for the salaries that we're paying them. But again, this is where if we want to have quality care, we expect it at the hospital, we need to then support and encourage and really keep the doctors that we have on our island. We don't want to discourage them. We don't want them to leave. Because then again, we're back to where we don't have the services available. Cardiology procedures, this is our heart care area. We do pacemaker insertions, cardioversions, cardiac catheterizations, angioplasty and stents, pericardiocentesis. 14,000 patients were treated in that heart project, in the heart cardiac care area. Newborn deliveries, 2,459 for the year. We're now averaging about 300 births a month. That's when, with GRMC closing their services for MCH, we have increased our deliveries in the MCH area, including pediatric admissions. And so it's impacting us. But, we take care of them. And I've talked about urgent care, I've talked about the challenges in the emergency room, I've talked about DOC. Do you still need me to elaborate on that? Okay, so we can go on to the HR and personnel standing. The next slide. Total budgeted FTEs for fiscal year 2020 did not change from 2019. We kept it, we didn't increase it, we didn't decrease it, 1,230 FTEs. Of that, we hired 154 new employees, but we also lost 130 employees. So, again, the comment about us having a bloated personnel and bloated payroll, it really is not accurate. And these recruits are primarily like nurses, pharmacy aides, pharmacy technicians, radiology technicians, technologists, respiratory therapists, physical therapists, medical lab phlebotomists, primarily, again, in the clinical services is what we're hiring for. In terms of the RN staff, like I said, we do have 327 budgeted FTEs, and this is just staff nurse. category, and we recruited 55. We lost a correction on that. It's not 28, it's 41. So again, we're struggling with our RN staffing situation. RN vacancy rate is 17%. I want to bring up the nurse licensure compact. This is an idea, a suggestion that we're going to need your help to then see if we can establish or introduce legislation for Guam to become a member of the nurse licensure compact. And what this is that various states are members of this licensing under the National Council of State Boards of Nursing, where there's a mutual agreement that if you're licensed in Colorado, you come to Guam to practice, you don't have to go through that lengthy process of applying for a Guam license. We recognize and accept your license from Colorado. So again, it speeds up the process for you to get a license, for you to work as a registered nurse on island. We've got military personnel who want to work at the hospital to really, get their experience because they don't have like NICU, they don't have, a very active L&D. They want to come to GMH and work, but we tell them they have to get a Guam license. But with this nurse licensure compact, if we become a member with National Council of State Boards of Nursing under the nurse licensure compact, we can then have that mutual agreement for military nurses, for spouses of military individuals who are nurses. That will increase our pool of registered nurses who can work in our facilities, in our healthcare facilities, not just GMH, but all healthcare facilities on Guam, if they can get that license.
Is there a cost to that?
What's that?
Is there a cost to that?
Is there a cost to get a license?
No, to be a part of this,
I'm going to need to
Association.
refer to the Guam Board of Nurse Examiners. They've been in
Yes.
close communication with the,
Yeah, they've been working on that. In fact, we have a bill. They're trying to get buy-in by all partners, though.
Right.
We want to be assured that it's not going to work in the reverse, where we are actually going to lose nurses.
we
that-
lose nurses.
I know.
It's nothing new. We
So
lose
we're-
nurses all
I
the
know.
time. They relocate to the mainland because it's a higher salary they can earn. We lose them anyway. But the other side of that
Right.
is we bring in nurses who are
They did
experienced.
this not too long ago for the physicians, so they did approve
Yeah,
this.
so that's something I'd like for the legislature to see if you can
Okay.
introduce it. That will help us with our situation of nursing shortage. Because it's not just then again in the clinical setting, but also in the school, in academia, because they're experiencing shortage of nursing faculty too. Okay, medical services, physician staff, we do have about 13 emergency room doctors. Some of them are locums tenens, meaning they're temporary. And so they're not there all the time, they're not on island all the time, but they're there when we need them to cover and to staff the emergency room, at least 2 physicians per shift. We do have hospitalists. These are like our pediatricians, our surgeons, our internal medicine, who then are assigned specifically to make sure that when a patient comes into the emergency room, a hospitalist will follow through with that patient through discharge. Other resources, human resources that we really are critical to recruit, in the professional support services, we still have a need for an assistant administrator of professional services. Dietary administrator, we've been vacant in that position for years now. So, if we could recruit God bless you, a clinician, a dietary clinician who can be the administrator, that would help. We need in the regulatory compliance area, patient safety officer. We had one and we lost him, again because of pay. And the requirement for this patient safety officer is that individual has to be an RN. So it adds to our challenge. In the fiscal services department, accountants, billers and coders, medical records administrator, and patient registration. It's an ongoing process of trying to recruit for these positions, but another challenging area. Operations, assistant hospital materials management. I think we recruited somebody for that. Did we? Yeah, we've got that in process of filling. Right, and then we need buyers and we need biomedical engineers. We're also working with Department of Labor because they have grant for funding for then healthcare workforce development program. So we're in collaboration with them to help us with like coders who need to be certified. So we're working with that agency. And then other highlights, updates, on-call pay. See, we're trying also to see where we can cut back on cost. And this on-call pay program, we've decreased it by 50 to 60%. Previous years, we were paying $500,000 to $700,000 just on on-call pay. Not overtime, not anything else, but on-call pay. We've managed to cut that down by 50 to 60%. So we're working to see how we can cut back on our cost and increase our revenues, so that way we can keep our financial status, at least very viable and sustain it. Pyxis system, we launched that. This is an electronic medication administration system where the nurse enters her code into this box that has the medications. And when the nurse enters that code for Maria to get this medication, it immediately, because it's electronic, connected to then the billing system. And so it's an accurate and a cleaner billing process and accountability for medications that we administer. So it's really just a great system that we just launched recently. We started it in OB ward and labor and delivery. We're going to move to the urgent care area. Because of our network situation, we're doing it at a slow pace because we don't want to crash our system. Accreditation CMS certification update. We had the CMS complaint survey just recently in August. We haven't received the official statement of deficiency report from CMS, but we have already pretty much started the corrective actions based on the preliminary exit conference of what the citations, what the deficiencies were that they verbally explained it to us. The laboratory count, we just recently again got reaccredited. And it's every 2 years, the surveyors, the College of American Pathology, they come on premise, surveyors, and they look at all our records, our QC processes, and how, again, laboratory services are provided. And we have, regained or renewed. We continue our certification with a CAP. So that's a big accomplishment. And it's pretty much recognized by CMS. So if they see this CAPS accreditation, they pretty much, certify our laboratory CMS. Sorry, I was rambling too fast, but any questions?
Thank you. I have a couple questions regarding so we went through staffing very quickly, and you talked about the challenges you're having for nursing primarily. How you've actually only increased your staff by 20 total? It's because you've got 154 new hires, but resignations of 130.
Correct.
And you've increased the pay of the RNs, yet you still need more. You have a vacancy rate 17%. Yes. You gave us some suggestions to supplement that. Okay, let's get to this. So you talked about hospitalists and the 2 doctors per shift needed for ER. Can you just clarify, the news recently, and I know you've done this also on the radio, but regarding physicians, I guess, holding full-time positions in the hospital. So what other full-time positions are there if they are not hospitalists or the 2 ER?
Okay. Are you talking about our chief medical officer who is full-time? That's the associate administrator?
I don't know. Can you give us a list of those? What are they? Yeah.
Okay. Well, to start from the top, we do have Dr. Annie Bardalio, who is our chief medical officer.
Are these considered physician positions or administration positions?
Administration.
Okay.
Okay. And so she's holding a full-time job as the chief medical officer, same title as associate administrator of medical services. We have Dr. Jolene Agun, who holds the title of assistant associate administrator of medical services. I've got her also tasked to oversee the assistant administrator of professional support services, and clinical services. That is the leadership that provides the clinical, oversees both nursing and professional support. Professional support, we don't have anybody in there. So in addition to her role as assistant administrator or associate administrator of medical services, associate administrator of clinical services, she's also taking the duties and responsibilities of the assistant administrator of professional support services. That position oversees the ancillary services of pharmacy, radiology, laboratory, respiratory care, dietary, social services, education. What else did I miss? But those are the departments that fall under professional support services. She doesn't get extra pay for that. It's just a flat rate of what she's making as the assistant associate administrator of medical services. In terms of other doctors who are full-time, the hospitalists are the ones who are full-time. Some are part-time, some pediatric hospitalists are part-time. We've got OBGYN hospitalists who are full-time. And so,
How many full-time hospitalists?
you know what, I don't have that number right
Okay.
now. We do have 161 doctors and medical providers and licensed practitioners such as CRNAs. These are your certified registered nurse anesthetists. They are considered licensed practitioners, and so they're privileged to provide care at the hospital under the medical staff office. 161 is what we've got. We've got full-time anesthesiologists, 4 full-time anesthesiologists. So they're staff doctors. We've got 4.
No, I'm asking about staff doctors.
Okay.
Because the ones with privileges, they come in and out? I mean, or are you paying them as part of your staff?
We're paying them to come in when we need them, to be on premise when, they're scheduled to work. So yes, if they are full-time, some are part-time. They're not all full-time.
Yeah.
Some take
Approximately,
on-call.
how many are full-time?
How many are full-time?
Yes.
I don't have that number right now, but I
Is
can
it,
certainly
are you
get that
talking
to
over 100, or are you talking?
No,
20?
not over 100 doctors are full-time, no. They have their clinics. They don't want to be full-time with us.
That's why we want to know.
Right, and I will get that number to you, exactly,
Yeah, but
how
what,
many full-time.
approximately 20, or, I mean, how many do you employ
Probably
full-time?
20, but not 100.
Okay.
But I'll get
because-
that.
All right, so you've got your 2 ER per shift, you've got hospitalists, approximately 20. These include surgeons, internal medicine, and other.
Pediatricians,
Pediatrics.
OBGYNs.
Okay, great. And then you have only 2 administrators who are physicians.
Correct.
Okay, and you have, all
We
right.
also have a pathologist, Dr. Abe, in the laboratory. He's
In the lab.
full-time.
Okay,
Right,
great.
he's full-time.
Right.
So him, and then we've got the 4
What about,
anesthesiologists.
I can't remember the term, Dr. Lizama had that position before, it's like the chief physician at the hospital. What is that?
Medical director?
Yes, medical
That's-
director.
That's Dr. Annie Bardalio. She's medical
Oh, so
director.
it's chief medical officer.
Chief medical
That
officer,
is an
medical director.
administrative position,
That's
not
an
a
administrative.
physician position.
Right, it's an administrative,
Oh, okay.
overseeing the medical services. We have Dr. Vincent Duenas, who is the medical director for SNF.
Oh, okay.
So,
So these numbers that you've given us don't include the SNL?
don't include.
SNL has a different set of numbers, you're saying?
In
for
terms of
physicians?
staffing?
Yes.
In physician, right, I didn't.
Okay.
But we
Okay.
only have 1 doctor over,
Okay.
actually 2, 1.5. Dr. Duenas is the medical director.
Mm-hmm.
Dr. Larry Lizama focuses on the clinical management of those residents up at SNF, and he's half-time there.
Okay. And what about the ICU?
We have a medical director, and that's Dr. Jolene Agun, who also oversees ICU as medical director.
And that's a staff position?
Yes.
Oh, so how many, sorry, do it again. How many medical directors do you have in the hospital?
We have, Dr. Abe, medical director for laboratory. We have Dr. Duenas, medical director for SNF. We have Jolene, Dr. Agun, medical director for ICU. We have Dr. Reynaldo Lim. He's not called medical director, but he oversees, he provides the leadership for the anesthesia services. We have also Dr. Arisueño, who is the emergency room medical director Can't think of any other areas that have medical directors.
How are medical directors employed? Are they GG1 like us, or
Dr.
are
Abe
they
is
contract?
GG1, Dr. Duenas is GG1, Dr. Lizama is GG1 as half-time. Not medical director, but he's the clinical medical management person for SNU. Oh, and Dr. Jolene Algan is, she's on a contract, I think. Hers is a contract.
So does it vary with the different?
Yes, that's what we are discovering. There are many
Yeah,
different
that's what we want to
ways.
understand also.
Yes.
I'll be frank with you. So it's not clear. Some are, employed by the hospital, some are on
Right.
contracts, some are on 2 contracts or 2 employments. Yeah, that's what we want you to, if you could make that clear for us, because you know that that's been discussed in the media.
Sure.
So make it very clear. Yeah, how are you doing the hiring, or is it?
Some of it is through the recruitment agency, locums tenens, that we use for doctors to bring them in, and so they're on a contract. They come in on a contract. Some of them.
Those are temporary.
They are. They're
So
very
no, not that. I'm talking about your medical directors.
Okay. They're hired if, okay, Dr. Duenas, we need you to be medical director at SNU. Are you willing to do it? So we hire him on a GG1. So,
Okay. So
he's a staff.
why are they different? Some are GG1, some are contract.
I guess it just depends on the way that we can utilize their services, because they also have their clinics and they want to be able to have that flexibility to go to their clinics, and that's something we're looking into with Dr. Annie Bedalia. We're looking to see how we can make a consistent pattern and have some criteria, and we're reviewing the contracts also. We're looking at that as a concern, as an issue that we want to try and fix and have some consistency in how we bring those doctors, because we have discovered that they're coming many different
Okay,
ways.
and yeah, so I've received several, complaints about
Sure.
hiring of doctors, that it's not fair, it's not transparent, it's not bid out publicly so that everyone gets a fair shot at it. That the salaries that are set are, now this is from a Pacific Island News article, that they're very high compared to other states, and they listed the states for the patient ratios that we have. They're saying our salaries are way high for these doctors, and I guess so I'd like to know how you set those salaries. So how do you determine whether GG1 or contract? How do you determine what the salaries are going to be? Okay. And I'm not criticizing any of these doctors. I'm just saying it's what the public wants to know, is what is your process? How did you get to this, and why does it not look the same to all of us,
Well, we do advertise. It's an ongoing advertisement for nurses and for all other professionals. We advertise it locally. We advertise it nationally. We advertise it through the publication, the journals, that physicians and nurses subscribe to. As far as the salary, we are
Is there a
using.
reason you don't advertise locally? Or do you?
It's an ongoing advertisement.
Do you advertise locally?
I have to verify with our HR what, publications that they use other than the PDN and the Post. We advertise there.
That was one of the allegations, that it's not advertised locally at all.
Well,
So
it's not
just-
true. We advertise. We even advertise verbally. Wherever we go, they say, hey, will you be interested to come and work? So, we advertise and we talk to people. We ask them, do you have anybody who's a relative, or you have a relative who's a doctor? We advertise on an ongoing basis through many different ways. We announce it, we tell people, we need doctors. As far as the salary, we're using and we're referencing the Medical Group Management Association. This is MGMA, that we recently just started using to see how we can then, gauge what salary we can offer them, the median, the highs, the average. And so that's what we are now using. Previously, I don't know what was used, but for our time that we started, we're using something that is standard, that is nationally recognized by the medical groups.
All right, can you just also explain between you, the administrator, and the board, what are the differing roles in this hiring process for physicians and primarily.
Okay. If it's a contract that we bring them in, we discuss it at the BOT HR subcommittee. And
Board
we
of
also-
Trustees.
Board of
Subcommittee,
Trustees
okay.
Subcommittee, yeah, HR Subcommittee. So we discuss it. If we do recruit a physician, again, we present it to the BOT HR for recommendation. Primarily, it's really the privileging also that gets approved by the board. But anything as far as recruitment, we discuss it at the BOT Subcommittee HR.
Salaries also?
Yes, even salaries, absolutely.
All right. And who has the final approval?
It depends on how then we recruit the physician, but we are going to start using, having the BOT approve it through the BOT HR up to the main BOT committee, full board.
All right. There was also a couple more allegations. One is that merit bonuses were not being paid. What is the status of merit bonuses?
We haven't paid any merit bonuses because
For
of our
years?
financial, for
It's just
years,
been
exactly.
stopped?
Yes, we haven't paid that.
No plans?
There was a moratorium on it. We'd like to, again, depending on our funding, we'd like to pay people and recognize for the hard work, the above and beyond outstanding work that they do. Absolutely, we'd like to pay them, but given our financial situation, we're not sure that we can, but that's something that we would like to look into.
All right.
And bring it up to the BOTHR.
Thank you. There's also an allegation.
Actually, during the last administration of Governor Calvo, we actually paid one merit bonus,
Like 1 year's worth.
1 year's worth, and then we just never went beyond that because of finances.
Yeah, I was told, back prior years
Yeah.
that they were lacking. Okay. What about, are there non-medical staffing or personnel at GMH that are not necessary, that can be transferred? For example, this was one of the proposals made publicly, transfer the HR staff or utilize DOA or, find efficiency somewhere else like that. Have you ever looked into this? Now that I did not see in the task force reports or anything, but is that something that you have looked into?
We'll discuss it at the BOTHR, absolutely. But yes, we have recruited some HR specialists into our HR department, and so we now have a full-fledged of 7 HR, not necessarily all specialists, but different categories. And it's really for our facility. I think it meets our needs because we also there's a drug-free workforce program that HR needs to really get on the ball to implement that consistently. Because we have a concern with drug use, and we want to make sure that we follow that policy. That policy's old; it needs to be upgraded. We're also looking at having our own personnel rules and regs because we've been using the DOA. We've adapted it, we've been using it, but we're retrofitting it to how our HR needs are. And so we have a task force looking at that HR personnel rules and regs. But for HR, we finally now have a really full-fledged
7 people.
department. So
All right.
I don't
and
see
7
that
only?
area.
7 in that
Yes,
department?
7,
Okay.
yes,
Well,
7
yes.
people.
Well, the general sentiment, I guess, not mine, but others are that there are too many non-medical staff. We need to look at efficiencies there. And so all I want to know from you is, so in your time now as the administrator, have you looked at that, or have we determined that there's no efficiencies to be found there, and in fact, we're short-staffed? I mean,
We're short-staffed, absolutely, in all areas.
in all these
in all
administrative,
areas.
non-medical areas?
Well, non-medical are like your housekeeping.
Personnel, billing, collections,
short-staffed
public
in that
information,
area.
legal, and upper management.
Upper management,
That's
such
part
as?
of the list. I don't know.
Okay.
That's a list that was.
Well, we'll bring it to the BOTHR, discuss that, and take a look at our staffing pattern and see if there are areas that we can then, but then these are government classified employees. We have to make sure we follow the process.
I guess what we're looking for, are there any other efficiencies that we can look at in the hospital? Have you think you've maxed out looking at additional efficiencies there?
We can, we'll take a look at that.
Also, as we right staff the hospital, then it poses an opportunity for us to reduce the overtime in these various departments. And so we would prefer to right-size them and provide high-quality service and not have burnt-out staff, which is also going to be poor services. And then we're definitely reducing overtime.
Yeah, I mean, just like in the FM, facilities maintenance, we're short-staffed there. You know, and with the hospital operating 24/7, we're constantly having some issues, you know, that we need the staff. Procurement, we're struggling with having buyers to help with the processes of, you know, processing procurement of equipment and supplies, and so we're short-staffed there too. So patient registration, we lose people, we need more staff. People are out on extended medical leave, you know, again, we're short-staffed there. Medical records, we're short-staffed there. Our coders, like I said, we only have 4 coders. You know, for 11,000 discharges annually, or 40 to 50 daily, 4 coders is just not enough. So, you know.
We just recently lost one of our coders to retirement. We have a lot of folks that are retiring, and so we need to replace these folks. These folks are very experienced and often certified. So then we have to really go back to the drawing board to figure out how we're gonna replace that kind of talent.
Sure. No, I understand that, yeah, you've got specialties there at the hospital. It's very efficient to have them right there. And all I'm asking is, because it's a new administration and because, you know, they keep talking about it publicly, if you can just take a look with your board of trustees if there are any efficiencies to be had, and if there are, then, you know, we'll wait for your proposals on that.
Very well.
What about, so the accounts payable, these are obligations, including tax liabilities. Who decides what gets paid first? I want to know if this is an administrator's decision or the board's decision. Who decided not to pay the taxes at, you know, in those years? And is there a system now as to who's going to decide what gets paid and what doesn't get paid? How will that work?
I rely on the CFO, and we communicate, you know, let's pay down our payables, you know, as much as we can, given what we've got in our cash, in our account. What priorities, you know, 10 priorities can be, you know, 10 items can be 10 priorities. All one, you know, the taxes, the return, payroll, we need to pay our employees, vendors that provide pharmaceuticals, that's another criteria for priority.
Well, what I'm saying is, when you're facing one of them not getting paid, who's going to make that decision in the future, going forward? Because obviously somebody made a decision not to pay withholding taxes. Right. We are now, years later, trying to remedy this, and it's really actually criminal, right?
Well, yeah.
So I want to know now, who is going to ensure that this kind of stuff is going to not be overlooked? So the administrator makes the sole decision with what gets paid in the accounts payable.
I would have to be the one to make sure that those are paid.
So the board has no role in that?
We inform the board, and we can then also we maintain an open communication with our board, particularly the chair. On a regular basis, I communicate with her. But as far as the ultimate decision, I'm responsible for that. You know, I have to make that decision that we have to make the payment.
Is the board formally appraised of what you might be short of in every pay period? You know, is there a formal process where they can hold you accountable, for example, the board, that you're not paying the taxes?
There is a process in terms of evaluation of my performance if I'm not doing my job.
But how will they know?
Communication. And
how will they know about
meetings.
the finances is my question. How will they know about the finances? How will they know what is not being paid, what's being paid?
At the subcommittee of the audit and finance, that's where all that discussion is in terms of our finances. And then it goes up to the full board, a report from the chairperson of audit and finance. That's all discussed there.
So would you say that all the board members were aware that withholding taxes were not being paid?
When I found out, when I came on board in January, I was informed around February because we were dealing with the CMS surveyors. And so we were trying to mitigate that matter. I reported it to the board when we had a board meeting in July. We had a board meeting in August, and I did inform the board that there is this issue that we owe withholding taxes for the years, for prior years, and the amount estimated to be $6 million. We were trying to resolve it by doing some kind of a check swap because it was done before. DOE owed us at that time $6 million. We owe DRT $6 million. We met with DRT to see how we can resolve it. We couldn't resolve it. And so I got the letter from DRT that, because we failed in
But you're
paying-
describing what you explained to the board, right? And I'm just trying to get a process going forward. So
Okay.
what is the board's action? It sounds like there is no board they have no role in that.
Well, again, I can't answer for the past, but going forward, this is what I'm making sure I communicate with the board where we are with our finances, the plan for paying those withholding taxes that we owe. Maybe we don't have a formal process, but we do have an informal in terms of communicating with the board. Does that answer your question? No?
It answers the question. I guess, part of what CMS also, right, was citing us for was board governance versus, administrator decisions solely. And so all I want to know is, and I think the board members should also be very, they should know, what are they liable for with this hospital? How are they going to hold this administration accountable? How is the public going to know this kind of stuff? And if it's solely reliant on an administrator disclosing it to them, informally, that's different than a very formal, like a report of these are your accounts payable and these, an accounts payable report that they are privy to.
And we do that at the BOT of Finance and Audit Subcommittee.
Subcommittees,
Right.
all right.
If I may clarify, what CMS cited us on was the board was not fully engaged in the quality assessment and performance improvement.
Yes.
That's where we failed to make sure we engage and we discussed it at that level. We were doing it, management and executive was doing it, the department managers were.
They want the board engaged, and you guys
But they
came
were
up
not
with a...
getting it all the way to the
Right, and
to
so
the
now
board.
you've come up with a formal process to
Absolutely.
show the board's engagement.
Right,
That's
we
very
do.
good. All right. Senator Rajel, did you have a question? Senator Taitzigui?
Thank you, Madam Chair. And thank you, Lillian, and everyone here from GMH for being here this late hour. I really appreciate it, and appreciate all the hard work that you put together. I'm just surprised that there is no board members here.
There were.
There
They were? Which one are they?
That's
Okay,
Michael
one. Can you raise your hands, please? Okay, 1, 2. Okay, so feel free if you want to make a comment, because we'd like to hear from you. I mean, if there's something there's a concern that you have, and one of the questions, of course, that the good chairman was trying to make was, is there anything in place to stop anything that's not legal, moving
Sure.
forward? And does the board have that authority to say, no, don't do it, yes, you can do it? So it's basically, go ahead.
Even at the full board meeting, well, sometimes there's executive sessions at the full board meetings, and remember now also we have a legal counsel. We have our own legal counsel that's advising the board, and so if there's a major issue like this one with the taxes, I mean, it's our job, fiduciary responsibility, to inform the full board what's going on, and then of course they're voting on issues and if they think we're going on a wrong course of action, they're gonna guide us in a different direction.
Okay. And you mentioned something earlier that you have a mechanism in place to monitor the board's work or whether they're there. I mean, a lot of times in the past you couldn't even meet quorum, and so how is that working out since the beginning of this year?
Our board, executive staff or secretary staff communicates on a regular basis via email and even via telephone and WhatsApp, their availability of meetings and also a schedule of meetings. And so there is that close communication with our administrative office.
So you've been able to meet quorum every single time?
Yes.
That's good to hear, because that was one of
Yes.
the biggest things
Yeah.
that was missing in here.
If I may add also, we do also have what we call an executive management council.
That's
This
the
is where the executive team meets regularly, and we have an agenda, what to discuss and what to then make sure we follow through. Whereas in the past, that ZMC was not really meeting regularly. For whatever reason, I don't know, but we're making sure that our executive leadership meets on a regular basis, and we discuss those issues.
That's the one I was talking about earlier, what is that? You have a mechanism in place.
We do.
Regarding that. Lillian, I reached out to you earlier, I think it was this week or last week, and sent a letter.
Last week.
Last week, and sent you a letter,
Yes.
as well as an article that the good chairman was mentioning, basically pulling from that and
Correct.
wanting your opinion on it. I appreciate your response.
Yes.
However, that one thing about why isn't Guam Memorial using the procurement process like they do with other departments and agencies? So you're outside of the procurement process. That was
No, we follow the procurement process.
in hiring.
With the hiring?
With
Well,
the hiring.
again, yeah, we'll look at that.
I appreciate that.
Professional services,
Yeah,
yes.
and I mean that's a big concern, and I'm sure the article that I attached to my letter, you read that article. Is the board
Yes.
familiar with that article as well? Have you presented that article to the board for them to read?
No, I haven't. The last
Okay.
meeting of our board was last month on the 20-something.
Okay, well, I
right.
would appreciate it if you can share with your board members
Sure.
that article that came out, kind of explaining what the good chairman was talking about earlier and the concerns that we have.
Sure.
But, again, I'm excited about the Army Corps of Engineers, coming in, and please keep us abreast about that. The only other thing is I'd like to know what your, the deductible on the insurance, the one that you have in September, I'd like to know that. And
Okay.
other than that, thank you so much for your hard work, and I greatly appreciate everybody at GMH, especially the conditions that you're working in. I greatly appreciate you still sticking it out. Thank you
you.
so much.
Senator, since you brought up the issue about that article, I do want to make sure that I correct. There was that statement that says nurses are not allowed to do overtime anymore. That's untrue. It's absolutely incorrect. It's
I'd like, in
false.
fact, I'm
Right.
quoting you.
In fact, we're encouraging nurses, if they can work overtime because of our backlog of patients in the emergency room, I say, come on, we'll pay you overtime.
And just for the
So that's
listening
so untrue.
audience, that statement that nurses are no longer allowed to overtime anymore. Yeah, that's
untrue.
I like how you put it. It's fake news.
It is. It's fake news. It's untrue.
I like your
false.
answer. Fake news. Thank you, Lillian.
Thank you.
Okay.
You've reduced their on-call pay, though?
We have.
Right,
We
okay.
have reduced.
Is
the
that
on-call
also
pay.
for physicians where you get that
No,
savings? Just
no, it's just the-
nurses?
right, just
Nurses
the
on call?
Not nurses only, but there's also professional support,
Okay.
like echocardiogram technician. We have also radiology technician, pharmacy technician, who we discovered do not need to be on call. So we have really cut back, we scaled back on that expense.
Senator Shelton? All right, if I could ask you just a couple more questions. And this is, again, miscellaneous things that come into my office, and I just want to clear the record of these if you can. So one was, of course, the birth certificates are being held until bills are paid. Is that a formal policy?
No, that,
If you could check into that, if
Yes,
that's allowable and
okay.
an acceptable policy. Also, fees for copies. I think I talked
Yes,
to you
you
very briefly
emailed
about
me.
this casually, but they seem very high to lay people. If you could just explain fees for copies?
Right. We do have a charge of making copies, which is standard. It is standard in all healthcare industries and clinics that if you want copies of your records, there is a fee. It's not really that expensive. I think it's either $2 per page.
Per page.
Right.
So if they want a copy of their medical record in the hospital because they're going to a doctor or off island, yeah.
Well, this is where, again, electronic health record, if we have that system really robust, and we can then forward them, copy of their medical record. And so rather than duplicating, paper, we can send it to them through their email. And then they can keep an electronic copy of it wherever they go.
In 2019, did you receive any money from the GMHA Trust Fund fee? Trust Fund?
Is that the limited gaming?
Yes.
Okay, we received that for the urgent care. We use that for
Right.
the operations
How
of
much
urgent care.
did you receive? And that's not in our budget,
It's about
right?
500,000, I think, is what
In
we
2019?
received. Yes.
How
I
much
believe.
do you expect in 2020? Same or more?
What was budgeted in the Healthy Futures Fund? Gosh, I'm so sorry.
Are you
but
saying the Healthy Futures Fund amount is
There
this?
was, it's budgeted. The Healthy Futures Fund in the 2020, there is a budget
Right.
allocation for it. We haven't received it because it's just the beginning of fiscal year 2020.
Rodham, can you clarify if that's the same, this GMHA Trust Fund is the same as the Healthy Futures Fund?
No, ma'am. It's two
It's the
separate
limited gaming.
funding. So,
Because this one is not showing in the budget.
right.
Right.
So with the GMH Trust Fund, that is specific legislation, Public Law 3260, I believe, and that is for urgent care.
Right.
And so we used to get a subsidy in there. So last year, or rather, the year just ended, so fiscal year 2019, we did receive 500,000, but then later on, I think it was just in September, I want to say we received another 1.9 million. We did submit a report to your office to that regard because there is a quarterly requirement as well.
Okay.
So that was submitted to your office.
And to Senator
Maybe to
Tina
the
Barr,
speaker.
Oh, I'm sorry.
Yeah.
Speaker. It was
My
submitted to
apologies.
speaker.
It was
Yeah.
the Speaker
I'll
Barnes.
check there. I
But we
didn't
can
look.
forward that
Okay,
if we
great,
need it.
thank you.
That was in March.
Oh, March?
March, it was March when it was
Were the
submitted to
additional or the
speaker.
report?
No, what was
But in
allocated.
September, an
There was
additional?
one recently
Okay.
submitted.
Another one
Yes,
recently.
ma'am.
Okay.
All right, okay. And so that's all used for urgent care right now?
Yes.
Okay. All right, so we're going to just expect some follow-up with a couple items. DOI funding, right?
Yes, ma'am.
For the past couple years, what you have received and what you used it on. FY 2020 DOI, or the Compact Impact money, not all the DOI, but Compact Impact in particular is supposed to be used for DOC payments to you. So if you can please keep us posted as to whether you are receiving your DOC payments.
Okay.
And,
You wanted accounts payable over 90 days?
exactly, yes, the accounts payable, that whole accounts payable, if you could tell us what those items
Sure.
consist of, yes.
Okay.
We are going to follow up with DOA regarding excess funds, so whether they're going to be deposited in the account for the capital improvement projects. They told me October 20 is when they might reconcile or do the next CRER.
Okay.
So we'll cross our fingers there. I'm hoping that, we're going to digest what you've said tonight and see what else we can do. And again, like I said, I know many of you who are here. Is there anyone else who wouldn't to testify? There was no one who signed up to testify tonight? All right. And I know that there are many, many other issues, and that like we said earlier, we're dealing with short-term issues, and so now we have an idea what you are promising to take care of in FY20. If things change, please keep us posted. I think we really want the public to follow GMH along. I think part of the issue is, even for me, trying to follow, and when we jump from one to the other, that was urgent yesterday, not urgent today. That's very confusing, and it makes us kind of lose motivation, right, as to helping in these urgent things. And we don't want to run our hospital with urgent. We want to have a long-term plan. And like I said, there are long-term discussions that have been going on for years, and so we hope to build on that. And I would like to be informed if you are having formal discussions regarding the long-term new hospital, like you said, is your recommendation, and if that is part
my
of what you are
personal-
working on, I really want to know that, because right now, it looks to me like that's not being worked on formally, right? That we're all kind of still waiting for information from different sources before we make any more moves on that. And otherwise we have a plan laid out, right, of what we're going to have to take care of if we are going to move in that direction. But in the interim, we want to assure everyone we are going to get quality patient care, continue our quality patient care at least for 5 years while we do whatever other plan is coming on. So thank you for the repairs that you are making, and please keep informing the public, Lillian. I like it when you get on the radio and you inform them what's going on. It's very concerning, these issues for patients and their families, their elevators and all of that. So please, as much as you can, I would encourage that you just tell them directly, let them hear it from you, what's happening, how fast it's going to be fixed. And we're all trying to be patient, right, with our 41-year-old facility. But we want to make sure too that the people of Guam are getting value for their money. And so we are trying to get as much money to GMH as possible. We want value. We want good decisions. We want the board to be very actively involved and hold everyone accountable, because that's the only way this is going to work. So, and I want to thank all of you for your hard work. My colleagues, thank you for being here. Thank you all for being here and your concern for GMH and your hard work. So this
Thank you.
hearing's ended at 7:25.